Now, looking in the Q&A, there are no questions already typed in. There was a question, I think, in the chat for you, Liz, around which I think you've partly answered. But I just wonder whether you'd be willing to just talk about that again. So I think the question from Stuart was, patients using digital health apps extensively can be looking at their health data more often, giving them more time and attention to it than their care team. So there will be many that see and understand the trends in their data more than their care team. For example, I mean, if for an inpatient on a ward, you know, the nurses might do their observations 4 times a day. The doctors might only see them once or at best twice a day, but the patient has probably got a full video of their data throughout the 24-hour period. So I just wonder if you had any comments.
Yeah, absolutely. And I suppose that this is why it's so important that we make sure that people have access to high quality digital health tools. If a digital health tool that they're using is giving them poor data or weak data or unsafe data or unreliable data and they're acting on it, that causes a problem. Now, the big challenge in this space is, of course, the volume of data. So if you wear a wearable and you go to see your primary care physician and you have a 10-minute consultation, your wearable will collect more data about your health in that 10 minutes than the NHS will ever hold on you, irrelevant as to how complex your care needs are. And so the sheer volume of data, and that's actually both an opportunity and a challenge. So as a clinician, how do you embrace that data in a meaningful way? And I described, so there was a situation a couple of years ago where Apple HealthKit integrated the data from the Apple Health app into an electronic health record. And no doctor ever looked at that data. And the reason why was because it was a vomit of data. That's the best word to describe what it looked like. It wasn't usable. And it also opens up challenges around professional duty of care. If I look at data and I don't do anything when I maybe could have done or should have done, what does that mean? So there are lots and lots of challenges. The other thing is authentication. How do you authenticate that the data from that digital health intervention is from the patient that's saying it's from them? How do you verify that data? How do you enable consent? So there are, the system talks about interoperability, being able to share data, but the challenges associated with doing that job are massive. Now, that isn't to say that it's not insurmountable, and it's not to say that I don't think in the future we'll have an opportunity, but I think the first opportunities will be exactly where this question is stating, which is in the hands of the patient or the person, because I can understand and manage the data for me as an individual, but probably as a clinician with hundreds or thousands of patients at the moment, that might be a little bit too challenging. So I think we're on a journey. I think there's a massive opportunity, but lots of challenges yet.
So, Liz, just to move off that, when people develop these apps, I mean, I know that commercially they would obviously be doing user group surveys and focus groups and stuff, but I mean, shouldn't they come with instructions for use as well, to say, you know, if you've got your 24-hour blood pressure, the fact that you and I might have a peak of 200 at one point probably doesn't mean very much if it's a peak for 5 minutes, but to a patient might say, oh my God, you know, am I going to have a stroke when my blood pressure is 200?
Yeah, I mean, this is a massive gap, actually, what you've just described. So I know I use the analogy of prescribing drugs. Now, when you get a drug prescription as a patient, you then go to the pharmacy and collect those drugs. And at that point, you can get advice and ask those questions and go back should you need to. If you think about the deployment of digital health, we don't have that workforce there. And that causes, again, a massive challenge, because people have different personal preferences, different personal needs, different levels of literacy, different levels of interest in their own healthcare. And this is why it's not just about deploying digital health, it's about deploying the right digital health tool for the right patients at the right point. And I'll just give you one example. So I live with type 1 diabetes, and I was diagnosed with that condition when I was 30. Now, although my condition stayed the same, when I was first diagnosed, the tool that I needed is very different to 15 years on, and I'm a well-educated person in my long-term health condition. But if you'd given me the tools that I use now, then completely different need. And so it's what I really want to get across is this myth that one product will meet everybody's needs is a complete fallacy, and we need to move away from that.
Dilraj, did you have something to add to that on how do we make things usable at the patient interface?
I think a lot of this comes down to appreciating and understanding how many stakeholders we're trying to accommodate in this space. Ultimately, I think a lot of innovators come at this from, we want to innovate in healthcare, we want to do something impactful for patients, but obviously clinicians are gatekeepers in that relationship, and clinicians' needs are very different from patient needs. So Liz perfectly highlighted there that as a clinician, when I'm on the ground, I need to make effective clinical decisions, and I don't need too much information in order to get there. I need something closer to the actual answer. We all have that kind of decision algorithm in any clinic in our minds anyway. So the needs there are very different to what a directly patient-facing app should or would do. I think in the context of that, there's a lot of expectation management to put forth in this space. One, to particularly to patients, that, you know, just because you've got a ton of information in front of you and you could do something useful with that, that doesn't mean your clinician is going to be able to do something useful with that. It's not always contextually relevant. And oftentimes it's kind of an unfair burden to place on a clinician who's not necessarily in a position to accommodate all of those different types of data sets that a patient may have available. Similarly, I think, you know, including clinicians in part of that process of what types of information are suitable to actually make better clinical decisions, improve patient outcomes, is really important, not only in product development, but in implementation of any technology. It's oftentimes missed, and I think clinicians can feel a bit lost when kind of a new system is thrown at them. So I think it's a really delicate engagement process all around, but I definitely think that I think it's assumed that just because you've got Apple Health and it's got all of this data that your doctor can do something with it. It's not true, and we have a little bit of education to do there. I think will make a big difference.
Thank you. That goes on, I think, to Ed, your question around the variety of apps available, and I don't know whether you want to articulate your question directly.
I was thinking, Liz, particularly about generalists, general practitioners, and so on. I mean, a single specialty clinic could perhaps have a small set of apps that they find useful. They could share these with their patients. Patient and clinician in all follow-ups could be familiar with the same information, so that the evidence that they're discussing with the individual could be very shared information that both were familiar with the format and how it was going. But thinking of poor GPs with all the conditions that they cover, it would be a hell of a burden if they had to be familiar with every app that every patient is using for every condition. But then, if they're not familiar with it, and the patient is going to the diabetic clinic and using app A, their next patient is going to the rheumatologist and using app B, the GP, in trying to keep the general picture, is getting lost in an app's jungle, really.
You're absolutely right, Ed. And what's happening is patients are turning up at their primary care practice or at their clinics with their phone and saying, I'm using this app, and waving their phone at the GP. Now, that's quite scary, because as clinicians, we're not trained in this stuff. And that's why having a repository, the first question is, should my patient be using this product? So I want a repository that gives me access to not just the good, but the bad, so that I can search and say, do you know what? I don't know that product, but what I can tell you is it's unsafe and it's not clinically valid. Please don't use that product. But then the next point is, well, which one do I then recommend? And that's why we need a repository which allows us to find the right tool for the patient that's in front of us. So, you know, mental health is a huge topic of conversation at the moment. And mental health is massive. You know, there's 20,000 digital health products in that jungle you described. It's huge. And so, which one do I recommend? Well, the first thing is I need to be able to know which of those 20,000 are the good ones And we might come down to, maybe 4,000, still a huge volume. But then if I've got a teenager sat in front of me, actually we're probably going to refine that 2,000 to about 50. And then if it's a teenager that's got an Android phone, we're going to refine that 50 down to 10. And actually it's a process of elimination. Now, at the minute, the way in which we're enabling the system is through a filtration system. But where I'm really hoping that we get to is an integration and the electronic health record system. So the electronic health record knows the information about my patient. The system for digital health knows which product, and the two things can be matched. So that rather than me having to go into a repository, the best product for my patient's needs and demographic profile comes forward, and that becomes a suggestion.
So thank you, Liz. That actually brings on to a perfect question from the Q&A from Claire, which says she's concerned that it seems too individualized and all of that data coming in automatically. And she's saying there's a risk that if someone's blood sugar is high, they get blamed for ill health. And maybe treatment is refused if, you have a day when you eat some chocolate, or it's somebody's birthday, like it's the Queen's birthday today. If we get to needing health insurance, then the insurance could be withheld. So is there this data about you being shared that you have control over?
You're absolutely right, and a brilliant question, and I can answer this both professionally and personally. So the first thing is consent. I want to know what health data I'm sharing. And at the moment, when we download a digital health intervention, we don't know the answer to that question. It's really important that in the same way that when we open a pack of drugs, we can read the side effects. What are the side effects of this product? Is it going to share my data? The second thing is that piece around consent. I don't just want to say I'm going to share all my health data. I want to know what data I'm sharing to whom and when. Now, for me, I have well-managed blood sugars. I actually would love to share my data with my insurance providers because my insurance premiums are massive and I don't have the opportunity to prove that my blood sugars are good. So I would love to consent to share that data. Now, in another scenario, I might not. But I think what we need to do is really think carefully about not grouping people in big bulks and expecting everybody to have the same choice.
Sure. Thank you. Well, look, we're at 2:15. I'm sorry to cut the questions short. We have got scheduled a 5-minute break now. So what I'm suggesting is that people don't leave the meeting and then possibly struggle to join in. But if you want to just mute yourself and turn your video off and have a comfort break or a glass of water like me, or a guilty piece of chocolate, and we'll see you in 5 minutes when I'll hand over to Ed.